So we're going to start looking at the peripheral nervous system here, looking at the somatic and then at the autonomic nervous system. So when we look at the peripheral nervous system, we basically break it up into three principal divisions: the somatic, the autonomic, and the enteric. Somatic and enteric will have both sensory as well as motor neurons, whereas the autonomic is primarily a motor neuron output, either on the sympathetic or on the parasympathetic pathways. When we look at the peripheral system, it goes back to the myotome and dermatome issues that we saw when we looked at the spinal nerves coming away from the spinal cord, where we're going to be able to combine various spinal nerves together to form the peripheral nerves that we're going to look at. We're going to look primarily within the peripheral nerves coming away from the brachial plexus and the lumbar, lumbosacral, and sacral plexes. These are the nerves that are heading through the upper extremity and then through the lower extremity. We're not going to go in too much into the thoracic nerve roots and into the thoracic peripheral nerves. We'll look at that with the autonomic system. So the somatic nervous system is going to be organized very similar to how we looked at in terms of the pathways within the spinal tracts. So with the motor tract, we have the nerve root, that's the spinal nerve. This is going to form a nerve plexus. This plexus is going to be a junction point of various spinal nerves coming together. This plexus will form into the peripheral nerve, and this peripheral nerve will head out and then splale into its individual neurons, forming the neuromuscular junctions at the motor end plates that are going to regulate the function of the skeletal muscle. On the opposite side of this, we have the sensory pathway. The sensory pathway is going to start with the receptor. I have another video that shows the various types of peripheral somatic receptors within the skin. It's a clip of the receptors that we skipped when we talked about the integument. Those receptors are going to link onto the peripheral nerve through the neurons. That peripheral nerve will then head into the dorsal root ganglion, where it will then go into the spinal cord either to synapse on an inner neuron or to ascend or descend along its various tracks and pathways. So when we look at the peripheral nervous system, in particular the somatic part of the peripheral nervous system, we generally have two organized pathways, two organized plexes. The superior one is known as the brachial plexus. The brachial plexus is a combination of cervical and thoracic nerve roots. The lumbar plexus is inferior to this, and it's going to be a combination of the lumbar and sacral nerve roots. So here are the various plexes that we just indicated in terms of the cervical. The cervical and thoracic plexes coming together to form the brachial plexus is going to run from C5 through T1. That will junction together, and we'll walk through the junctions in a couple seconds here, to form all of the peripheral nerves heading out into the upper extremity, such as the axillary nerve, the median nerve, the radial nerve, the ulnar nerve. Coming from a nerve plexus within the cervical region, we get nerves such as the phrenic nerve, which is why, so if you look at C1, C2, if we happen to have a spinal cord injury in that area, the phrenic nerve, which is responsible for ventilation, controlling of the diaphragm, gets damaged and the person is unable to breathe. Now, if we slide inferiorly, we get to the lumbar plexus, or slide caudally, we get to the lumbar plexus, the lumbosacral plexus, and then the sacral plexus. So the lumbar plexus is going to be nerve roots coming away from all of the lumbar nerves, whereas the lumbosacral plexus is going to be a plexus of nerve roots coming away from a combination of the lower two lumbar nerves and then the upper three sacral nerves. And then we get the sacral plexus, and the sacral plexus is going to be the nerve roots of the sacrum coming together to form the plexus. These are going to give rise to the principal nerves heading to the lower extremity, in particular the sciatic nerve, as well as the femoral nerve. But then we have other nerves, such as the obturator nerve, the gluteal nerve, that are going to come away from these plexes. So the first thing we need to look at, and then I'll show you why they do this here in a second with another diagram, is the breakdown of the plexus. So the brachial plexus starts with the nerve root, and notice we're going from C5 through T1. These nerve roots come together to form what's referred to as trunks. These trunks get broken up based off of how they anatomically orient themselves, where the most superior is the superior trunk, the most inferior is the inferior trunk, and then the trunk in the middle is the middle trunk. Because it now has to pass in between the costals, the clavicle, and the coracoid plexus with all, the coracoid process with all of the overlying and underlying musculature within the axillary region and within the pectoral girdle, we now have to shrink those 3 trunks into 2 trunks. And so we call these trunks divisions. And so the one to the anterior side of all of this combining, this convergence, is the anterior division. The one to the posterior side will be the posterior division. The posterior division is going to form the posterior cord. This is going to be the cord that is going to be closest to the subscapular fossa. The anterior division is going to break into 2 parts. We're going to have a lateral cord and then a medial cord. The cords themselves is what's going to give rise to all of the nerves that we see within the upper extremity. From the lateral, we're going to get the musculocutaneous. From a combination of the lateral and the median, we're going to get the median nerve. From the medial, we're going to get the ulnar nerve, as well as the pectoral nerves. So the lateral is going to give us rise to the lateral pectoral, and the medial is going to give us rise to the medial pectoral. From the posterior cord, we're going to get the radial nerve, as well as the axillary nerve, the thoracodorsal, and the subscapular nerve. Now, there's a couple of nerves that are going to be involved with the control of the upper extremity that don't necessarily come through the plexes, but are involved with the nerve roots that join the plexus. And this includes the long thoracic, the dorsal scapular, and the suprascapular nerves. So we just broke down the divisions in terms of the cords and the trunks and the divisions and the peripheral nerves that are coming out. So if you look at the anatomy of what's going on, this is why we have to truncate and combine nerves together as we pass through. So notice the small amount of space that you have in between the first costal, rib number 1, costal number 1, and then the clavicle. So all of these nerves have to pass in between those 2 structures, along with the scapula that happens to be there and the coracoid process. There are some nerves that are going to pass along with the rotator cuff in between the clavicle, the acromial process, and the greater tubercle of the humerus, where if we don't allow enough space to take place, we actually start getting impingements. One of the impingements that can take place is what's referred to as a thoracic outlet issue. We will usually see that with people who happen to have had an upper extremity injury, or someone who doesn't follow proper seating posture in terms of ergonomic, where they have that caveman posturing, where we close off that space for the nerve to come in. And one of the easiest things that we can do in order to open up this space is what's referred to as brachial stretching. And I'll show you a video clip of that, or I'll walk you through it when we do our meeting. Coming away from the brachial plexus are all of the nerves heading down the upper extremity. And so we will get from the brachial plexus The nerve that's going to head to the biceps, the musculocutaneous nerve. This musculocutaneous nerve also is going to have the lateral cutaneous nerve, which is going to continue down the radial side of the antebrachium. It's not the radial nerve, but it's going to give us sensation to that lateral aspect of the antebrachium, as well as the lateral aspect of the elbow. We get the median. The median is going to cross onto the anterior surface. It's going to cross in front of the antecubital region, and it's going to continue all the way down into the dorsum of the hand. So what ends up happening is we can actually follow these pathways along in order to determine where we have neural deficit. So the median nerve itself is going to give sensation out into the digits of pollis, indices, and media, whereas the ulnar nerve is going to give sensation into minimi, as well as onto the dorsal surface of the hand and wrist. So people who have things like carpal tunnel issue will have compression on that medial nerve. People who have decuvein tunnel syndrome will have compression upon the ulnar nerve. So the ulnar nerve is going to pass along the medial aspect of the humerus. It's going to come along and it's going to continue through the epicondyle. In fact, there's a little kind of notch on the medial epicondyle, and you can palpate it on yourself. And if you flex and extend your arm, you'll feel that nerve kind of pop in and out. And that's where the quote-unquote funny bone for the person happens to be. Now, the radial nerve is going to pass along the posterior surface of the humerus and then continue along the lateral aspect of the humerus, heading all the way down the radius out to pollis, and it's going to give us sensation as well as motor control through the common extensors, whereas the median is going to, the ulnar is going to give us common flexor along with the median. Now here's the lumbar plexus. Now what you'll notice is that there's a difference here, and we're missing something that we saw in the brachial plexus. We don't have the cords, and the reason why we don't have the cords is because we don't have that anatomical limitation on space. There's a lot more space within the pelvic region and with the abdominal pelvic area in terms of lack of bony structures, so we don't have to converge things together, so we can keep things the way that they are. Now, if you notice, there's a lot more nerves coming into play here. So the lumbar plexus is going to come from the nerve roots of L1 through L4. The lumbosacral is going to give us from L4, L5, and will draw from S1 and S2. And then the sacral plexus is going to draw from L4 all the way down to S5. Now notice the lumbar plexus is going to split. The lumbosacral plexus is going to split, and the sacral plexus is going to split. Now notice I have anterior and posterior labeled twice. The reason why I have anterior and posterior labeled twice is not because there's two anteriors and two posteriors. It's just which ones are coming together to form those distinct factors. So we have an anterior division coming from the lumbosacral and the lumbar plexus, which will give us nerves such as the saphenous, the obturator, and the genitofemoral. But then we also have the anterior division that's going to come from the sacral plexus and only the sacral plexus. And that's going to give rise to the posterior cutaneous femoral, as well as the tibial division of the sciatic nerve. Now the lumbar plexus and the lumbosacral plexus will come together in terms of the posterior division to give rise to the femoral and the lateral femoral cutaneous. So the lateral femoral cutaneous and the musculocutaneous nerves are two of the nerves that we actually saw on the cadaver when we were doing the dissection. So those were the couple of the nerves that I had you save as you're going through the subcutaneous adipose tissue. The posterior division coming from the sacral plexus is going to give rise to the superior and inferior gluteals, as well as to the nerve of the piriformis and the perineal division of the sciatic nerve. So the perineal division of the sciatic nerve is going to be on the fibular side, whereas the tibial division of the sciatic nerve is going to be on the tibial side. Now notice, just like with the brachial plexus, we have nerves that are not going to be directly coming from the plexes, but are involved with the nerve roots that become the plexus, such as the iliohypogastric, the ilioinguinal, and the pudendal nerves. So here is the pictorial representation of those plexes come together. So notice we have a lot more space that we can play with that we didn't have when we looked at the brachial plexus. And so this image here is kind of explaining why we don't have the chords that we saw when we looked at the brachial plexus. And so here are the peripheral nerves coming away. So coming from the anterior divisions, we're going to have all of the nerves that are going to go ahead and traverse along the anterior surface of the thigh and then down through the leg, through the crural region. From the posterior divisions, we're going to have all the nerves that are going to traverse along the posterior aspect of the thigh and the leg, or the sural region. So notice that the longest of these nerves are the saphenous as well as the femoral. And then we have the sciatic on the posterior aspect. These nerves are continuous throughout the length of the leg as well as the thigh, with division branches coming off, giving sensation all the way out to the digits as a continuous branch. So unlike the upper extremity where we had multiple branches going to the hand, we only have two branches heading down into the foot. Notice where the sciatic nerve is passing along the sciatic notch, right where the head of the femur is going to be meeting up with the acetabulum, right close to the ischial tuberosity, where you can very easily compress that sciatic nerve. Now there's a muscle that's going right in that same spot there, known as the piriformis, and that piriformis actually has the sciatic nerve bifurcated. It actually splits the piriformis. If we spend a lot of time sitting, the sciatic nerve can get compressed within the piriformis due to what's referred to as piriformal compression. If you spend a lot of time sitting, you start getting your foot fall asleep or dead foot. That's because either the piriformis has compressed on the sciatic nerve or the ischial tuberosity has compressed on the sciatic nerve, putting it into a period of absolute refractory period, where if you start moving around, the compression goes away and then you start to have the foot feel come back.